Great. Thank you, Jeremy. And thanks to everybody for coming to listen. I wish I could see all of you. It's so nice to do it via Zoom, but it's actually better to do it in person and have the social aspect as well and see faces instead of the computer screen. So this is a huge topic. It's impossible to talk about all of this in transplant. And like with all super specialities, you get subspecialities of a subspeciality. And probably the way that this is going is that transplant is an infectious diseases job, and you do nothing except the transplant infections. And in that, there's all the different aspects of each system and each transplant. So what I've aimed to do is give you a bit of an overview of the topic, to give you an idea of the kind of things to look out for, and to try and sort of trigger that this is not normal infectious diseases and really needs a whole different approach, and then to show you where you can look at these problems and where you can get extra help from if you come across a patient and are not used to dealing with transplant patients. So as we know, the number of people who are getting transplants is just accumulating and getting bigger and bigger every single year. In the US in 2017, they did over 34,000 transplants, and that's been more every single year. They never have a year where they transplant fewer people than the year before. 2017 was also a bonus year because they had more than 10,000 deceased donors. And I think that's maybe something to highlight, in that all of us and most people feel like we should be blood donors, we should be organ donors, but how many of us have actually gone and put our name on the registry? And as there's more and more awareness, there's more and more donors, and we're able to help more and more people. The nice thing about being an organ donor is that one deceased donor is able to help 8 other people and potentially save their lives, which is amazing. Every 10 minutes, another person gets added onto the US transplant waiting list. And despite all these numbers of people that are winning, 20 people die every day who are on the list and are not going to get a transplant. In 2021, again, over 40,000, and this is really amazing to me because despite COVID, in the US, they were still able to have such amazing outcomes. So what happens in South Africa? We're getting more and more and more organ transplants done as well, but we're really not on the same scale. So the most updated data from the Organ Donor Foundation in South Africa was from 2019. They did South Africa did 365 solid organ transplants. Around the world, similar facts in South Africa, we do the most of kidney transplants, and that's what we've got the most experience with from a transplant point of view as well as an infection point of view. So 216 adults got a renal transplant, of which 76 of those patients got a transplant from a live-related donor. The second most common is a liver transplant. 54 adults in South Africa got a liver transplant in 2019. 34 pediatrics got a transplant. In terms of the children, 20 of those children received live-related donors. Sorry, someone trying to say something? Okay. Heart transplants, 29 adults got a transplant. 1 pediatric. Sorry, it's my screen disappeared. Jeremy, I think it says host disabled screen sharing.
That's challenge. Hold on 1 second. Let me make you host. There you are. Sorry, Kim.
No problem. Okay, let me try again. Sorry, everyone. Okay, so the third most common transplants in South Africa are heart transplants. 29 adults got it, 1 pediatric patient got it in 2019. And then lastly, lung transplants. 13 adults received a lung transplant. There's other transplants that we do. Pancreas transplants in 2019, there weren't any. And then corneal transplants, which may be more common than kidney transplants, but probably not. But they didn't have the numbers for that. So we're getting somewhere. So again, I just wanted to put on a graph to show you the kind of transplants which are the most common and the kind of organs which can be transplanted. renal making far and away the most number of transplants, followed by liver, then heart, then lung. Some patients have a single procedure where they get a kidney and a pancreas transplanted. Some people get a pancreas, and then the other is really things like cornea, skin, and these days we are almost able to transplant just about everything. Now, why do people die after a transplant? And we always, at least in my mind, think that a huge percentage of it must be infection. Then that's really true. So in most transplants, infections still make up the majority of the mortality. So if you have a look here, in case of liver transplants as well as lung transplants, infection make up the vast majority of deaths after 10 years. But in renal transplants and in heart transplants, it's really quite reassuring that maybe we're starting to get on top of infections in these patients, and they are dying from vascular events. I guess it does make sense, specifically with the heart being so dependent on a really excellent blood supply. And often patients who need heart transplants, if these are ischemic related, we know that the rest of their blood vessels are not great anyway. But it is quite comforting to see that not everybody who gets a transplant dies because of infection. So what are the kind of issues in solid organ transplant? And what are the kind of things that make it a little bit different to infectious diseases? In the past, we had very few immunomodulatory or immunosuppressory agents to use in transplant. We had very broad immunosuppression. If you think of the cortisone, glucocorticoids, which suppress just about the whole immune system, making it open for almost any microbe to cause infection and damage the graft. Now we've got much newer immunomodulatory agents, and that's fabulous from a graft rejection point of view, but it does result in more opportunity for infection. With a lot of the immunomodulatory agents, the newer ones though, these are becoming more and more specific. And so one is really able to narrow down the kind of infections that one is going to expect. It does help from a diagnostic point of view and certainly from a therapeutic point of view. Along with newer immunomodulatory agents, though, we need newer diagnostic methods. So in the past, it was really difficult to make a diagnosis of certain viral infections, certain fungal infections, even some of the atypical bacteria. So as transplant medicine has progressed, we've needed to be able to identify the infection a lot earlier. And then once we realize that the patient has got an infection, and we'll see why that's important a little bit later, because it's not always infection, but we need to then be able to identify the pathogen and be able to treat them. And there've been huge advances in this in recent years. Now, never ever forget the importance of vaccines in the pre-transplant period specifically, so that we can try and prevent as many infections from happening. And really, any patient who's getting a transplant needs to be able to have something to prevent it as far as possible. And if you know that there's a disease that is preventable by vaccine, please try and make sure that the patient has it, preferably pre-transplant. Now, in the past, we used to have transplant lists where if people had a BMI that was over a certain level, they would not make the cut and not get the transplant. In 2022, it's really amazing because people, no matter what their BMI are being transplanted. And this is no longer really a reason that a patient should be on a cutoff list and be rejected from a transplant list. So that comes with other problems, though, dealing with issues around obesity. The surgery is more difficult, the drug dosing becomes more difficult, the complications are more difficult. So it's got pros and cons. Nosocomial infections in 2022 are really huge. And we know the issues around drug-resistant bacteria, CREs, ESBLs, XDRs, and along with that goes multi-drug-resistant infections, potentially community-acquired like tuberculosis. Very important are the new emerging infections, which are often in transplant donor-derived. So we'll talk a little bit about that. And then the difficulty of trying to diagnose infection in an immunocompromised host. So people whose immune systems are not as strong and as obvious as what they used to be can present with infection infection in very subtle, difficult to interpret and difficult to diagnose ways. The immune system is blunted. People often have minimal symptoms, very few signs of inflammation. And at first glance, one may think, oh, this person's not really sick, and not react quickly enough. Medication toxicity, unfortunately, remains a huge issue, although with the, like we said, newer immunomodulatory agents, this is becoming better and better every year. But along with suppressing the immune response, unfortunately, many of the rapidly dividing cells in the body are affected, and a lot of these drugs have got significant side effects. Then in medicine, we always try to say that we want to have a single diagnosis. In infectious diseases, we always try and work out the one infection that's causing the problem. But in transplant, this may not be the case. And often it's not uncommon for people to have multiple infections, which can make life quite interesting. And then lastly, it's not always infection. So it's often difficult to differentiate between whether the person has got an infection which needs to be treated, or are the patients rejecting their transplant? Is it a drug toxicity or something else that's causing the issue? So let's quickly talk a little bit about the sepsis. There's no classic features. Patients often present with a normal white cell count, and that may be because their bone marrow is being suppressed by whatever immunomodulation they've got on board. So one cannot rely on looking at a normal white cell count to say, oh, infection is excluded. Patients often don't have a fever in the post-transplant period, again, because of immunosuppression. And you need to really pay attention to very subtle changes, low-grade fevers, 37.4 degrees in the afternoon or in the morning may be very, very important in somebody who's had a transplant. People with solid organ transplants and infection often have more thrombocytopenia, so their platelets start dropping earlier, and that may be a clue that there's infection. There's also a lot more multi-system involvement and organ failure. So it often doesn't just affect one system, like with somebody with a normal immune system, but one has to look at all the other organs and see how the infection is affecting them as well, and then include them in one's management plan. Nosocomial sepsis in a person who's had a solid organ transplant, unfortunately, occurs 20 times more frequently than in patients who don't have a transplant. So one can really expect that in the vast majority of people who've had a transplant, they're going to have at least one nosocomial event. And along with that comes the higher microbial resistance, depending on what your hospital's antibiogram and what you normally grow is like. And that can make things really difficult to treat. We all know that people on immunosuppression, and specifically with transplants who get infection, fungal infections always need to be high on the list, and they frequently have fungal infections. And then along with that come viral reactivation, or in the case of a donor-derived infection, potentially new onset to a primary viral infection. And these don't present like the usual sort of viral infection, where it's often in a patient with a normal immune system quite easy to differentiate between virus and bacteria. The viral infection in a patient with a solid organ transplant can often mimic bacterial sepsis. And these patients make it quite difficult because one wants to give them lots of antibiotics, not understanding that it's actually a viral infection and the antibiotics are not going to do anything. And then the last thing to think about with somebody who's got a transplant is to chuck all the traditional severity scoring systems out of the window. So if you think about something as simple as the CURB 65 score for somebody who's got pneumonia, that becomes almost irrelevant in somebody with a transplant. You're not going to get the high respiratory rate necessarily. They're not going to appear so sick. And as we were saying with the previous slide, because these patients have got these blunted systemic responses, one's really not able to pick up the severity of the infection as easily. And it's very simple to discount them and say, oh, you're not really sick. Go home and come back in a couple of days if you're not better. And by that stage, the guy's rejecting their organ in florid septic shock and really very, very ill. So let's talk a little bit about some of the emerging donor-derived infections. A couple of years ago, with the outbreaks of Zika, this became very important infection to screen for and test for in patients who became sick after transplant, so Zika virus infection. And obviously now in the last 2 years, COVID-19 transmission has become very important. And I'm sure you, like me, have read some of the articles about people being denied transplants because they wouldn't have a COVID-19 vaccination. So you can have your own opinion as to whether you think that warrants a denial of a transplant, but really in such a difficult to control setting where so many things are happening, one really wants to be able to try to control as much as possible. And a simple thing like a COVID vaccine could mean the difference between life and organ rejection in that person. Along with this, we've started also becoming aware of the causes for some syndromes in the past where we didn't know what the cause was. One of these was the hyperammonia syndrome. So patients would become critically ill, have these massive ammonia levels, and have no understanding where this was coming from and what the cause was. And now with better diagnostic techniques, one of the causes of this has been shown to be ureaplasma species, the urealyticum, and some of the other ones as well. So it's been really interesting to see how with better diagnostics, we understand syndromes better and can figure out the cause. So what else has better diagnostics helped us with? So PCR and molecular testing obviously has made a huge difference. Gene sequencing has helped a huge amount with being able to figure out exactly what the organism is so that one can target therapy. Immunodiagnostics has become hugely important, specifically in CMV, which has been notoriously really a difficult organism to understand whether it's latent or reactivated or primary infection. But now we've had huge advances in the diagnostics and treatment of these infections. And then not only that, but the BK virus, which we'll talk a little bit about earlier, at least later, tests for monitoring who's had BK virus in the past, who is seropositive, whose seropositivity is changed. And this does also make screening and monitoring a lot easier. Now, there have been therapeutic advances in many infections. And in the past, people who were HIV positive were, first of all, not eligible to be organ donors. But in recent years, we've seen the transplant between HIV positive donors to HIV positive recipients. Our drug therapy is amazing now, and one can really achieve excellent results in patients who are HIV positive and who receive either HIV positive or HIV negative grafts. Similarly with hepatitis C. In the past, it was absolutely impossible that we would want to transfer an organ from a hepatitis C donor into somebody who was hepatitis C positive or negative. But with the advances in treatment for hepatitis C, we've got cure rates around 96 to 98% with the new treatments. This has now become an option. And in first world countries, they are considering and have used grafts from hepatitis C positive people being given to patients who are hepatitis C negative, and then watching to see whether they need treatment and treating earlier rather than later. Well, in terms of invasive fungal infections, we've got newer drugs which are far more effective, have less mortality, morbidity associated, fewer side effects, such as isoflurane in patients with invasive Aspergillosis and mucormycosis. And then in patients with resistant CMV, which is always a really difficult one because once one's gone through ganciclovir and foscarnet, there are often very few options available, but these therapeutic options are starting to become more available and we're able to save more people. Excuse me. So remember, just a word quickly on anybody that you're counseling who may be going to have a solid organ transplant to really consider their pre-transplant vaccination status. And basically the bottom line is you want to vaccinate them for absolutely anything which is possible to receive a vaccine for. Do be careful about the live viral vaccines though. So one really wants to give these in patients way before they get their transplant. such as the varicella vaccine, the measles vaccine is another one. But now, in specifically pediatrics, it's not such a huge issue anymore. And in certain selected cases, one may consider giving a live viral vaccine to a child after the transplant, but this is not the rule of thumb. Try and avoid live viral vaccines in patients who are post-transplant and on immunosuppression. So what are the kind of things that predispose to infection, that predispose to graft rejection, the different kind of complications following a transplant? And is there a way that one can try and reduce these effects? Or is there something which we do commonly to give us a bit of hope that one is not going to have graft rejection in the future, and maybe we're not going to be able to need to use all these immunosuppressants? So we know that the transplant will disrupt the composition of the commensal microbial flora, that normal flora, which we're starting to understand has got such huge consequences for health and well-being and a multitude of diseases in the future. So a transplant patient usually receives their transplant through surgery. Their diet is often changed whilst they're in hospital. Then they put onto immunosuppression. Then they put onto a huge amount of antimicrobial prophylaxis. They may or may not get infection. We've said they often do have some or other kind of infection, and hopefully they've had some vaccination. So all of this disrupts the host's microbial baseline microbiome and results in dysbiosis. And that's associated with development of chronic rejection. So dysbiosis is associated with everything. It affects everything. And as far as possible, one really wants to have an excellent gut microbiome. Now, is there a way that we could make resilience of this microbiome and restore the diversity of the pre-transplant flora? So in other words, we've altered it so much with all our interventions. Is there a way that we could sort this out in the pre or post-transplant period to try and improve the allograft outcomes? One of the things which has been considered is the role of microbial manipulation, for instance, by a fecal transplant. Could this be a therapeutic measure to improve allograft outcomes eventually? And probably with time, we're going to start understanding how we can improve these outcomes to maintain a normal microbiome and have therapeutics which are really so specific to the graft and preventing the rejection of that graft without affecting the rest of the system. But this is probably years away still, unfortunately. So let's get on to some more of the specifics about and around solid organ transplants and trying to work out the infection. There's two very important slides in this presentation, and this is the first one. So if you don't remember anything except this slide and another one a little bit later, then you're doing very well. So the first important thing is that we want to understand when the person got the infection. And I'll show you a table, which is the second important slide, to show you exactly how that works. So always ask yourself, in somebody who has had a transplant, how many months or weeks after your transplant did you start showing signs of infection? Then the next couple of questions are what we as infectious diseases physicians would ask anybody who's got an infection, with one small difference, and that is that we want to know what chronic diseases, latent diseases, comorbidities the recipient of the transplant has. But not only that, we want a little bit more extra information and to understand what kind of underlying chronic or latent infections the donor of the graft had. And the transplant physicians will have this information. Not for everything, you can't test for everything, but there's a huge number of tests which get done on the donor pre-transplant, and one does have the answer to some of these questions. So always ask yourself, what did the donor have which could have been given to the recipient, and what infections does the recipient have which could reactivate because I'm giving them immunosuppression? The third thing is the epidemiological exposure, which we love asking, and we always ask any infectious disease patient. The fourth thing is we want to know what organ did you receive, because there may be some clinical associations which are top of the list, which we always want to exclude in any person who's received a kidney, for instance. And we'll quickly go through some of those. Fifthly, what immunosuppressant drug are you on? And that is important because some of the immunosuppressants specifically predispose or are risk factors for certain infections. So one would think about those first before going through the rest of the list. And then to help you rule out infections, always remember and ask what prophylaxis are you on? Not only antimicrobial prophylaxis, but what vaccines did you have before you got your transplant? Or did you get a live viral vaccine in the post-transplant period, which might help us work this out? And then lastly, is this really infection? Or could this be rejection or drug toxicity? So always remember these 7 questions. And I'll stick this up again just now. So donor-derived infections can be anything. Any kind of infection can be transmitted from a donor to a recipient. The most common ones are usually viruses, specifically the human herpes virus, and this is the most commonly screened for in any organ transplant. What is your serostatus for herpes simplex 1 and 2, CMV, and varicella zoster? So those are very important. Many of the immunosuppressants can reactivate these infections, and we really want to know what the donor's seropositivity is and the recipient's seropositivity for human herpes virus. HIV is obviously also always properly screened for, but sometimes people do die in the window period, and a false negative HIV test could mean transmission of HIV to the recipient. There's always some interesting ones, people who die with diseases where one's really not sure what's gone on, and unfortunately, organs are transplanted into a recipient who subsequently develops terrible things like rabies infection, LCMV, West Nile infection, etc. Remember that people could have TB or non-tuberculous mycobacteria and go on to cause infection in recipients if they're carrying that. Think about syphilis. Also think about MDR and XDR bacteria. So patients who've been in hospital and are either colonized or had infection with a drug-resistant nosocomial associated bacteria or virus like the BREs, ESBLs, MRSAs. Parasitic infections, there have been case reports of people getting babesia, getting trypanosoma infection, getting strongyloides. Really, any infection can come from a donor-derived source. So this is how they denote it in transplant. So if the donor is seropositive for infection, it becomes D+, and the recipient is not seropositive, the recipient is R-. And when you're making notes on a patient, you always want to know for each infection, is a D+, R- is the worst kind of thing, because then one always wants to think about a donor-derived infection, which could have been transmitted to a recipient who has not been exposed to that infection previously. So let's quickly have a couple of words on the different kinds of common transplants and the sort of associations that one would think about with them. So in order, the most common transplants are the renal transplants. What kind of infections do people who've had a renal transplant get? So most patients following a renal transplant, if they get an infection, would have an infection involving the genitourinary tract, usually a pyelonephritis, could be as a result of reflux, could be as a result of the new anatomic changes. And I'm not going to discuss all the different kinds of infections which are possible, but I wanted to say a word on BK virus because most of us never really heard about BK virus until you start dealing with transplants. And it's not something that's on our radar. So this is one of the polyoma viruses, and it's specifically very important in renal medicine because it infects a kidney. So the other polyoma virus you'll remember is called JC virus, which we deal with in patients with AIDS in the brain, causing an encephalitis and a kind of syndrome up there. So this BK and JC virus come from the same family. Both BK and JC virus probably infect the vast majority of children. So infection occurs during childhood. Most of the time, both of these viruses are completely asymptomatic, and we don't ever worry about them until the person becomes immunosuppressed. So the problem with BK virus is that the adult seroprevalence rates are around 65 to 90% by the time you're 10 years old. So almost all adults have had BK virus. And the problem is that then this can result in a polyoma-associated nephropathy in the transplanted renal graft, or a hemorrhagic cystitis. So in renal transplant, always think about BK virus reactivation. There isn't serology widely available at all. It's become available now recently, but in the past, it wasn't something that we screened for to see who had been exposed to BK virus and who hadn't. And it's really quite a difficult virus to diagnose in terms of PCR, etc., because there's difficulties trying to understand latent versus activation and reactivation, etc. So always think about BK virus when you deal with renal transplant, and that's the only infection that we're talking about specifically. The rest's all going to be very broad. So I just wanted to show you quickly, this is one of the renal transplant screening checklists. And these kind of viruses and other infections are pretty standard for anybody who's going to have a transplant. So they look for CMV, IgG in donors and recipients, EBV in donors and recipients, herpes simplex, HIV, HTLV1 antibody, varicella zoster antibody. It's important to know whether the recipient is immune so that you could consider vaccinating before the transplant, because remember that it's a live virus and you don't really want to give it post-transplant. Hepatitis C, hepatitis B. Again, for hepatitis B, try and vaccinate if possible. So even in somebody who's critically ill, needing a transplant, to give a vaccine to them before they get their transplant, their immune response and humoral immunity is going to be so much better than giving that same vaccine to them afterwards when they've post-transplant and got all the immunosuppression on board. We check for syphilis. We look for things like seropositivity in the recipients to measles, mumps, rubella. These are the typical vaccines which are possible to give. And then we also look for TB, either latent or active TB in both the donor and the recipient. If the patient has had a liver transplant, what are the kind of things that we look for? We look for anastomotic leaks, abscesses, bacteremia from enteric organisms. So always think about gram-negative infections in patients with liver transplants. And then lastly, wound infections, abdominal wound infections are important. Heart transplants, patients most commonly get pneumonia with either bacteria or fungi. Remember that patients with heart transplants need to have a sternotomy in most cases, and osteomyelitis can grumble on in a very asymptomatic and low-grade way without anyone ever thinking about it, and can present years later with problems. Mediastinitis is an absolutely devastating complication, which we hope no one ever gets. And then something a little bit strange, think about toxoplasmosis, because you can have latent toxoplasmosis in heart muscle. In terms of lung transplant, always remember, obviously, pneumonia. It could be from colonization, pre-transplant or after. Patients can aspirate organisms. The ventilator support, which often carries on for quite a long time afterwards, can cause issues. And in lung transplant, it's really important to see what kind of prophylactic antibiotics or antimicrobials the patient is on. So the immunosuppressive agents, we want to know what kind of immunosuppression they're on. And the three main outcomes or reasons to have the immunosuppression agents or important things to consider in transplant are obviously because these agents suppress rejection. But the side effect of that is that the acquired immunodeficiency obviously is going to lead to infection, and in some devastating cases, even to neoplasia. And then, like we've mentioned already, the tissue toxicity from some of these drugs is quite significant. So I want to quickly go through some of the immunosuppressants. There's basically 5 big classes: the corticosteroids, which you're all very comfortable with, small molecule drugs, which include the anti-proliferative drugs like azathioprine and MMF, I think most people are quite aware of these ones. The calcineurin inhibitors, like cyclosporin, tacrolimus, the inhibitors of the mTOR pathway, like sirolimus and everolimus, and then the newer protein drugs, which are polyclonal and monoclonal antibodies. So the polyclonal ones are the ALG and ATGs, so anti-lymphocyte globulin and anti-thymocyte globulin, which is the newer one. And now in our age, the monoclonal antibodies are probably going to overtake all of these, and we're starting to get down to very specific inhibition with lots and lots of new pathways. So the corticosteroids, as you know, predispose to a wide range of infections because they are so broadly immunosuppressing, inhibiting cell-mediated immunity as well as humoral-mediated immunity. And one really doesn't want to give vaccines when patients are on corticosteroids because of the humoral immunity, which is so suppressed. Corticosteroids specifically think about activation of TB and PCP. Azathioprine, the main target are activated T cells, but it also impairs and suppresses B cells. Azathioprine specifically can result in major viral infections from the human herpes virus. But again, it's so broad, it causes neutropenia, which can cause bacterial infections, fungal and parasitic infections as well. MMF inhibits inosine monophosphate dehydrogenase, and that decreases the proliferation of activated T cells as well as B cells and impairs the humoral immunity. If you're on MMF, specifically think about viral infections, especially CMV should be top of your list. And strangely enough, and we don't know why, MMF actually protects against PCP. So if you've got a lung infection that looks ground glass, first thing CMV before worrying about PCP. The calcineurin inhibitors, tacrolimus and cyclosporin, they impair the T cell synthesis and suppress proteins involved in lymphocyte activation. Often patients are on combination medication, so you can't say that it predisposes to a specific infection only. Often viral infections, BK virus and the human herpes viruses. And then remember that cyclosporin is associated with chronic Epstein-Barr reactivation and the PTLD, so the post-transplant lymphocyte diseases, lymphocytic infiltration diseases. mTOR, this inhibits pathways needed for messenger RNA translation and enhances viral entry into cells. So many of these, like rapamycin, etc., there's a long list now. One, again, there's a common pathway. You always got to think about viral activation. The antibodies, ATG and ALG, we're getting more and more ATG being used now, less ALG. And these two drugs are often used initially in the induction phase of immunosuppression and then are stopped a bit later. They cause depletion of T cells, and that results in human activation, BK virus, PCP, and other invasive fungal infections. The antibodies, every week there's a new monoclonal antibody. They're very, very specific, targeting very specific components of the immune system. So my recommendation is if you get a patient who's on one of these drugs, look specifically to see what the common associations are for whatever monoclonal antibody the patient is on. Okay, we've kind of gone through this now. So this is the second most important graph or slide. And I just want to take a minute to go through this. So once one has got a history, and we said the first most important question is to ask what the timeline of the infection is. Did the patient develop symptoms within 1 month of transplant? Was it within 6 months of transplant? Or is it after 6 months of transplant? And this is really important because it helps us to work out what kind of infection the patient has. So within 1 month, one is going to think about pre-existing infections, which the recipient has got. So reactivation of your own infections. The second thing we're going to think about the kind of infections that we would think of in any patient who's had a surgery. So nosocomial infections, hospital-associated, what's happening in your own hospital? Do you have VREs, or is it an MRSA, or is it just an ESBL? And then in some cases, uncommon, donor-derived, and then the recipient derived kind of colonizing organisms. So this makes it a little bit easier because you often don't need to think about the rare and strange canaries, but rather think about the ordinary infections that one would associate it after surgery. Within 1 to 6 months, this is when the person is starting to get established on their immunosuppressant drug. And so opportunistic infections typically occur in the first 6 months as your body's not used to all this immunosuppression. And so these are where one needs to think about strange infections like the BK virus, need to think about crypto, need to think about TB, need to understand what kind of prophylaxis the patient is on. Are they getting Bactrim? If not, it could be PCP. So I think we're pretty good at thinking about opportunistic infections because of our HIV. So in the 1 to 6 months, think about an HIV person because many of the immunosuppressants drop the T cells. So whatever an HIV positive person would get, those are the kind of things that you're going to think about. And then in patients who are over 6 months, the immunosuppression is often being weaned, cut back, and patients are sort of in a better homeostasis, more tolerant of infections. And in this case, a lot of the time, the infections which they get are community acquired. They can, of course, get fungal infections. They can get more subacute infections which don't present quickly and obviously, like nocardia or rhodococcus. And then again, the viral kind of reactivation syndromes. So in any transplant person, one is going to pull up this slide. And this is the original one, which I'm sure all of you have seen 1,000 times, but which really, really helps to focus your mind and try and figure out exactly what's going on. Okay, in the interest of time, I'm not going to go through these 2 slides, but just to try and mention that when an infection is diagnosed, obviously the dilemma becomes what to do with the immunosuppressants. One is really hard-pressed to stop the immunosuppression completely because the graft is not going to make it. And so it's really difficult to convince a transplant specialist that the immunosuppression needs to go. And the good news is that in most cases, it doesn't need to go. It needs to be decreased, and there's all kinds of ways in which one can do that. But in anyone with an infection, to get control of the infection, the immunosuppression is going to have to be decreased. So that was that slide. So I just want to remind you, because I want to end off with 2 case studies to try and demonstrate how to think about a transplant infection so that you can start getting into the rhythm. So remember, as we're going through these cases now, what is the timing of the infection? Is it less than 1 month? Is it 1 to 6 months? Is it more than 6 months? So take a screenshot of this slide quickly or pull it up on your phone. The second thing is, what did the donor give the recipient? And what did the recipient have underlying? What epidemiological associations can I make? What organ is it? A heart, a liver, a kidney, whatever, lung? What immunosuppressant drug is the patient on? And what kind of infection predisposes as a result of that immunosuppressant? Has the patient had any vaccines that I know of? What antimicrobial prophylaxis is the patient on? And could this just be a rejection or a toxicity? I'm saying just because obviously infections are the most important thing. Right, so have a look here. We're going to go through 2 cases and we're going to have a couple of polls to see what you think is happening. So please do vote. Remember that it's anonymous, so it doesn't matter if you get the answer wrong. Please vote anyway. So the first case is a 46-year-old lady. She had an orthotopic liver transplant. Orthotopic means they put the liver in the same place that the old liver was in, and she needed the transplant because she had biliary cirrhosis. Her donor, unfortunately, had died because of intracerebral hemorrhage, so that's good news. Sounds like hopefully they didn't die of an infectious disease. And in terms of latent infection, the donor had EBV, CMV, and varicella zoster in the past, but was negative for hepatitis B and C and HIV. The recipient had also had Epstein-Barr and varicella. The recipient did not have HIV, hepatitis B or C, or CMV. The recipient was discharged on 14 days after receiving the transplant. Following ALG induction, she then had tacrolimus, MMF, and prednisone, and she also received Bactrim, acyclovir, and fluconazole. On week 7, she developed a fever, stopped eating, and had night sweats, had a white cell count of 2.8. They didn't tell me what the diff was, had low platelets, an AST of 357, and an ALT of 390. So, Jeremy, if you can make a poll for us, please. What is the diagnosis that you're thinking of? Are you worried that this lady is bacteremic? Are you worried that she's got tuberculosis reactivation? Do you think this is acute hepatitis B? Do you think it's CMV? Do you think that the patient has got fungal sepsis? So let's give it a minute to see what everybody thinks is going on over here. Remember, we can't see your answer, so you don't need to worry about whether you get it right or wrong.
Give another couple of seconds.
Okay, so just under half of you voted, and the majority of you, 75%, think that the patient's got CMV reactivation. A few of you are worried about fungal sepsis, a few of you are worried about bacteremia, and one each are worried about TB and acute hepatitis. Okay, so what is the answer? The answer is the patient had CMV reactivation. So what makes the rest of these diagnoses less likely is that, first of all, the patient was on Bactrim, which means that hopefully that's going to prevent a bacteremia. Second of all, tuberculosis. It's quite an acute presentation for TB. We can never forget about TB, and what's against or at least there's nothing that this patient is getting to prevent TB. She's not getting any kind of TB prophylaxis, but it doesn't really fit here. I'm sure you'll agree. Acute hepatitis B, yeah, definitely one needs to think about that. But in the previous slide, I told you that the donor was hepatitis B negative and the recipient was hepatitis B negative as well. So that makes it less likely that this is acute hepatitis B. But I agree with AST and ALT like that. One is thinking about viral things. CMV reactivation is important because of the previous serology. So the donor was CMV positive, but the recipient was CMV negative. What do we know about acyclovir? Is that it doesn't prevent CMV infection. It's not good enough. It's only good enough for the human herpes, at least herpes simplex type 1 and 2. And then, yeah, one definitely needs to think about fungal sepsis in a patient like this. What I just also wanted to show you is how, again, these kind of patients may get the feeling that there's more going on than a simple viral reactivation. The platelets are low, patients are having huge fevers, night sweats, and really seem to be quite toxic. So how's the diagnosis made in this patient? She had a liver biopsy, which showed an inflammatory cell infiltrate and had features of active CMV replication on an immunofluorescent test. This was done, a case from 2007 where they were still doing this PP65 antigen test, which we don't do anymore. She was CMV PCR positive with a very high viral load. Was started on ganciclovir for a week, had valganciclovir for 14 days, so 3 weeks in total. Her LFT normalized and her CMV viral load dropped very significantly and nicely. So well done, everyone who said CMV. Okay, this one's a little bit more difficult, maybe. I've given you a clue. So it's a 57-year-old man. He had a cadaveric renal transplant 7 months previously. So think about our last column. The patient is now getting infection in the post 6-month period. He had end-stage kidney disease that needed dialysis in the 7 months prior to the transplant. We don't know why he had renal failure. He had a twin brother who also developed the same thing and also needed a transplant. In terms of past medical history, he was hypertensive, had asthma and dyslipidemia, had no epidemiological features, but did mention that his daughter goes horse riding. He was discharged and was still on MMF, tacrolimus, and methylprednisolone. Now, most patients, the cortisone component is short-lived, and we really try and get rid of the prednisone as soon as possible. But in this patient, the steroids were not stopped because it looked like he might be developing acute rejection. And so the methylprednisolone was continued, and he was still on low-dose prednisone. And because he was 7 months down the line, his Bactrim prophylaxis was also stopped. So he was only on MMF, tacrolimus, and methylprednisolone. He developed a cough, hemoptysis, dyspnea, and right-sided pleuritic chest pain. He did not have a fever. His white cell count was 9.1, of which 82% of those were neutrophils. He was anemic with an HB of 10. He had a CRP of 18. His GFR had deteriorated from 26 to 21, and his LFT and electrolytes were normal. He had a chest X-ray, which showed him sort of mass, well-described left mid-zone lesion on his chest X-ray. And so they went on to do a CT scan, and this is what the scan looked like. So again, quite a dense mass in this area with a little bit of ground glass around it, maybe infiltrating a bit, and the rest of the lung field's pretty clear. They started him on Augmentin initially, but he didn't improve. And so they went on to do bronchoalveolar lavage, and everything from the lavage came back negative. So what do you think this patient has? Pulmonary tuberculosis, invasive aspergillosis, nocardia, rhodococcus, or strep pneumonia? Jeremy, can you put out a little poll for us, please? Thank you. So what do you think is going on in this patient? Is it fungal? Is it bacterial? That's nice. This time we get a bit more, it's not as polar, oh, it's a bit more polarized this time, I guess.
Cool, give another 5 seconds.
Okay, brilliant, thank you. So most of you are worried about a fungal infection. I agree, it is worrying, and especially because he didn't respond to the Augmentin, that makes us worry that this is something not bacterial. And then a lot of you remembered that I said that his daughter went horse riding and are worried about the rhodococcus. So what did they do? The one thing that was positive on the bronchoalveolar lavage was the galactomannan. So they thought this was probably invasive aspergillosis and started him on voriconazole. They decreased the MMF and the tacrolimus, but unfortunately, after the initial kind of stabilization with Augmentin and the voriconazole, the patient again continued to deteriorate and needed a readmission. This time around, he was totally hypotensive, really quite sick, had a lot of chest pain, dyspneic, and along with repeating the bronchoalveolar lavage, he had blood cultures, and he had a CT scan, which now looks like this. So still a well-circumscribed lesion, but now multilobar infection, and this time they were able to get a diagnosis from the blood culture, interestingly enough, and not again from the bronchoalveolar lavage. You can't tell me what this is, but basically these are gram-positive coccobacilli, small, and with the history of being exposed to horses through his daughter, a diagnosis of Rhodococcus equi was made. And this patient had disseminated Rhodococcus equi, which then improved dramatically when he was treated with imipenem and vancomycin. So thanks for participating in those 2 case studies. I hope this talk has given you a brief overview on how to get started with a patient who's got a transplant. And if in doubt, there's really amazing articles on how to get to the next step, what to do next, how to focus once you've answered those 7 questions, one's mind really on the specifics. And if you can Google specifically Transplants Infectious Diseases guidelines from 2019, there's a whole issue of one infection after the other, one system after the other, There's guidelines on CMV, guidelines on all kinds of managing specific infections in a transplant patient, and you'll really be able to do very well and get very far if you keep those 2 slides in mind and then Google for extra help. So thanks everybody for listening. It's nice to talk to you all again, and I see I'm just managed to finish on time.
Great. Thank you, Kim. Really nice talk. Very appreciated. I'm just looking through the chat. I don't see any specific questions. So if anyone does have questions, we can spend a minute or so on them. I think people are grateful mostly in the chat. Yeah, I mean, so I guess we'll just see if there's any questions. But I guess one important point just for the audience to get is the enormous difference, obviously, in solid organ and stem cell transplants. So that this is obviously, applicable as your title was, solid organ transplants, very different in terms of prophylaxis and spectrum of infections and timing and things like that for stem cell. But that's an entirely other talk for a different day. More than enough in this one. So thank you very, very, very much. For the first case, did they say why they didn't give CMV prophylaxis? Because they should have. Right?
Yeah, they didn't. And I was quite surprised that they gave acyclovir, but didn't think about giving ganciclovir. They didn't mention that, Jeremy. No.
Yeah, okay. Well, hopefully they learned their lesson. But that's great. Thank you. I don't see any other specific questions, so we can probably end there. But thank you. Oh, hold on. One question. Aside from TB, are there specific infections you think we should adapt standard prophylaxis treatment for in South Africa? Or things you rank higher in your differential in South Africa?
Well, RIPCA, perhaps HIV, until one can see that one is past the sort of window period for testing. Maybe that's something to consider. Other South African infections, I can't really think of specifically. Jeremy, can you think of anything?
No, I think TB is the big one, and it's very badly done in South Africa because people follow international guidelines without thinking much. But I think the other thing to factor in is the fact that the prophylaxis is very different potentially here due to cost and due to availability. Like, for example, in stem cell transplants overseas, the CMV prophylaxis would typically be letermovir. We don't have it here, and so the treatment is, it's quite different. So I think that would be the other thing to factor in. Is just the fact that the duration and type of prophylaxis may be somewhat different, although not massively so. I mean, we've got Bactrim, we've got Valganciclovir, we've got acyclovir, so it's not the end of the world, but there's little bits that are different. And then just the availability and the importance of screening, like Kim showed, for certain things, like, for example, strongyloidiasis, which is not always covered overseas. Which obviously may be more of an issue here. And again, South African transplant teams tend to be not good at looking for these weird things and tend to be quite limited in the workup they give. So I think that's another thing to be wary of, at least. It's a great question, and particularly I think TB is something that just needs much more thought in transplant than we give it locally.
Yeah, definitely.
Cool. All right. I think we can end there, but thank you very much, Kim, for your time. And you can see from the chats how appreciated it was. So thank you.